very good afternoon to the respected chairpersons here and the esteemed audience here. I will be talking about recent advances in pediatric cataract management. As we know that pediatric cataract, it is very different from adults and it poses lots of problems. And recently we have seen a lot of advancements in the pediatric cataract management in the form of safer anesthesia, newer techniques, newer IOL power calculation formulae, IOL designs, better understanding of neurobiology and genetics, and amblyopia management and adjuvant postoperative care. Coming to the pre-op evaluation, we have now availability of portable slit lamps, portable keratometry, swept source optical OCT, and HRES OCT, which has made our job much easier. The availability of minimally invasive instruments in the form of radiofrequency, diathermy, plasma blades, modern vitrectomy machines have facilitated our CCC, which has to be very round in pediatric population to facilitate IOL implantation. The future holds good for customized OCT, Zepto, and stem cell research. Now the question comes, when to operate these patients? The bilateral cataract patients, they are supposed to be operated from 6 to 8 weeks time. And if it is bilateral, of course, the second eye has to be either operated in the same sitting or after 2 weeks time, within 2 weeks time. Unilateral cataracts are from 4 to 6 weeks of time are to be operated. Now planning for surgery, if the child is around 1 year of age, one should go for lens aspiration, PCC, and limited anterior vitrectomy with secondary IOL implantation. From 18 to 2 years of age, lens aspiration with IOL implantation, PCC, and limited vitrectomy. From 2 years to 5 years, lens aspiration with IOL plus minus PCC. Older than 8 years, lens aspiration and IOL or plus minus PCC, because he can undergo laser later on. Coming to IOL power calculation, the handheld autokeratometers, the availability of ultrasound biometry in the form of immersion and application techniques, optical biometry, which are more precise and more error-free, are now available, which have given us more predictive value for IOL calculation. Immersion technique, as we know, is more accurate than application technique. The formula which we use for pediatric population is SRK-T and Holiday 2 formula, which have least predictive value. Dahan has given us a little rough estimate for correction in these patients. If less than 2 years of age, 20% reduction in IOL calculation, and from 2 to 8 years, it is 10%. Recently, we have the studies have given us one more formula in which they have predicted the IOL calculation, which is more fit for emetropia at the age of 15 years. Choice of IOL, we know that it is foldable, hydrophobic, acrylic IOL, which is most suited in pediatric population with square edges, which inhibits lens epithelial cell migration and PCO formation. The hydrophilic lenses with hydrophilic anterior surface and hydrophobic posterior surface are the perfect IOLs in pediatric population. Nowadays, more and more people are also going for toric and multifocals, in which the setting for astigmatism is very, in toric IOLs we can settle the astigmatism very quickly, and multifocals all can give problem-free post-operatively. Viscoelastics, we have to use high molecular weight OVDs in this population in the form of Helon GV and Helon 5. Tryphan blue dye, it causes capsular stiffening in these patients, which prevents a runaway rhexis. And in the anterior capsule, in the surgical considerations, we have mechanized anterior capsular rhexis, vitreorhexis, radiofrequency diathermy, Fugo plasma blade, which are the recent things which are in femtosecond laser, which has made our job easier. The rhexis, if it is more precise and accurate, our job is mostly done. The availability of foldable template intraocular rings are also available to make our capsular axis much precise. Now one concept is bag in the lens implantation, which many people are following, in which there is anterior and posterior axis is done 4.5 mm, and anterior and posterior capsules, they are put into grooves of the IOL, and it is thought that it is, prevents migration and proliferation of epithelial cells beyond optic edges. Capsular polishing and capsular optic capture also prevents the most dreaded complications in this pediatric age group, which is PCO and dreaded inflammation. Many of the our microscopes are provided with the Rexis assistant, which can help us do a round Rexis in these patients. Now, post-operative management, as we know that we have, if we can put heparin-coated IOLs in uveitic patients, and along with that, the intra-injection hydrocortisone or dexamethasone is given to prevent post-operative inflammation and phimosis of the capsule later on, and PCO formation. And along with that, to prevent we can give intracameral antibiotics, and cyclopentolate eye drops are recommended 3 times a day in most of the patients. Now our job is half done if we don't give post-operative refractive correction in these patients, and for which nowadays small diameter high plus self-adhesive lenses are available, which can be stuck onto the frame, and child can have good compliance with these glasses. Our job is half done if we don't go for amblyopia therapy in these patients, because many patients are reporting late to us, and we should be going for amblyopia therapy in these patients to settle the vision problem. And
ma'am, you can sum up.
Yeah. The artificial intelligence is now taking its role in the pediatric cataract management in the form of pre-op assessment and IOL calculation. And to conclude, the advancement in technology has remarkably improved in surgical outcome. Zepto and HRES OCT will be the future driving technology in these patients. The biggest hurdle remaining is precise IOL calculation in pediatric population. Okay, surgery is only a part of the management process, and the final outcome depends on post-operative follow-up, compliance, early detection, and amblyopia management. Thank you. Thank you.
We have